not be forgotten, but they need help. They are stressed out beyond all get out, really. And our topic today is we came up with embracing the discarded. Sometimes people tend to feel like they've outlived their usefulness, but there's always something that's there, and we've got to understand that. Our bodies may start giving out, but many times our brains are still functioning at a high level, as my colleagues will attest to here. I think I was a better physician at age 50 than I was at age 30, that's for sure. And it's because of experience. And I think you guys, Rick, Randy, you probably would agree with that too. Dale, I'm sure you would agree with that. It's our insight and our experiences. So I just wanted to start the ball rolling here. And so let's start by going around the room. Anybody have any thoughts, or just do a little brain dump here right now and get the conversation going?
Well, I call it invisibility. I think there's an invisibility that anybody in careers understands as you get older, because once you retire or whatever, you sort of fade into the background. Physicians easily go from being doctor to mister very quickly, and so that's a change. But I do think that's one of the key things about any mental health issue is invisibility, and we don't recognize it. Now I think we will, but so I think this is a great topic for discussion.
I'll toss this out here as well. I'm in the midst of working with elderly parents. They're 81 and 77, and they've just moved into an assisted living community, not necessarily in the facility proper, but they're on a condo, the first stages, if you will, into that kind of stair-step process. And we're fiercely holding on to as much independence as possible. But, I'm the daughter. I'm also a nurse. And so I'm switching hats a lot as I'm working with them. And I can see very quickly the need for emotional and mental health support, and the lack of resource in that area. As they moved, a lot of their emotional and spiritual and mental support came from their church group. And then with COVID, and their advanced age, they're not able to transport themselves. And then COVID put them in their condo. And so without either myself or my sister going in routinely and just interacting with them, the isolation is it's just so devastating. So, thank goodness that you see the need, Dr. Deshmukh, but you're doing something about it. And so I think it may be really good early in the conversation here is to ask you, give us a little bit of an overview, if you will, how you saw the need and what resources you have that you're applying to that kind of a concern.
Sure. So when I started working after my residency, the next day I was in nursing home. So June 30th is 2012 is my last day with the residency. July 1st, I was in nursing home. That was what I had signed up for, to provide services to nursing home, hospitals, and outpatient clinics. So it was a full spectrum that I signed up for. I did not know what I was getting into. I just wanted to join the private practice, come to Central Florida and do the work. So, but I realized that the nursing homes have tremendous need for psychiatric services and need for good psychiatric services, because there are psychiatric services out there which are not doing a good work, or just doing the work. So the good psychiatric services does make a big difference. That need was there, and I was just providing services to 5 nursing homes at that time. And the work that I was doing was from heart and was doing sincere work. And then word of mouth started spreading, and the need became very apparent, that I realized that more and more nursing homes needed that. to the extent that I had to eventually stop my going to the hospital. I had to give up my privileges there because the time was just not there to keep up with everything. And eventually I even stopped my clinic because then I was just wanted to focus on nursing homes and assisted living facilities, which are similar to nursing home, but a little more freedom and a little more homey environment. So I continued to work on that until recently when I realized that I have to do something for outpatient setting also, because when patients come to nursing homes and they go home, even at that time, they don't have uh, access and ability to go to psychiatrist offices, and the wait line is too long. So I thought I had to put some clinics now. So I started doing some clinic as of last 2 months. We have started working on 3 clinics in different areas to provide the continuity of care. But until now, it was just the nursing homes, assisted living I was focusing on. And I also have an addiction board certification. So I do half a day a week addiction residential rehab work. Um, so the need became apparent as I started working. In past, I used to get consulted only when the extreme issues were happening, like residents are being combative, or they're hitting each other, or they are super depressed and expressing wishes of dying. And at that time, they said, "Oh, it's time to call psychiatrist." But then, as the time went by, they realized the need to involve psychiatry even on the early stages, with early development of depression, early development of agitation, or loneliness feelings. So now they involve psychiatry and psychology to help the individuals. The reason being that if we don't do that, then the disease progresses and it starts manifesting into various forms, whether it is actions in forms of aggression, agitation, combativeness, or suicide attempts, or withdrawal. That is the later stages. We want to capture that early on. So not only me, it's overall the government has recognized that there is a need. So they came up with the regulations that now ensures that the patients in nursing homes get the mental health screening, get proper diagnosis if they have one, and then get the proper treatment. What other thing also government had recognized that the usage of psychiatric medicines in nursing homes was not appropriate. So on one side there was under treatment going on and patients were getting falling through the cracks and ending up in the hospitals or going to the psychiatric hospitals or having the complications. But on the other side, there are patients who really did not need such high doses of psychiatric medicines. They were receiving excessive medicines. And
Yes.
partly it could be because it's easy for the facility staff to manage a patient who is sleeping than patient who is actively causing problems.
Yeah.
Yeah.
So it's easy to keep patient sedated or less active. And that could be the reason that in past there was a lot of inappropriate usage of psychiatric medicines was going on. And families were noticing it. Patients were having falls, they were drooling, they were sleeping all the time.
Yep.
They were having extrapyramidal side effects. So many things were going. So federal regulations came strong on that, that you not only have to do screening, treat patients, but also get rid of unnecessary medication. So from both sides, the pressure came on psychiatry to do the proper job. And when that pressure came in, suddenly there was a rise for the need of good psychiatric services. Because primary doctors manage so many things that they are not expert in the psychiatry and they are not expert in managing the psychiatric medicines. So now there's a need for specialists to come and do this, run this program. And that's where my work really picked up. And we realized the need and started providing the need. So that was the answer to the first question about the need, what resources we have. So we hire mid-level providers, we train them through our online modules, through our in-person training, through our virtual training, through Zoom webinars. We use online chat platform where we discuss the cases, complex cases, and keep educating them. So with that, we develop the team of providers that can go consistently to nursing homes and assisted living, recognize the problems at early stages, and to treat them at early stages before they get worse. That's one track. And the other thing they do is to always assess which medicine is necessary, which medicine is excessive, what dosage can come down, and how to minimize the polypharmacy. So the goal is to keep patients' quality of life as high as possible, to keep them safe and comfortable in the setting that they're in with minimal medicines possible, so that they don't get the side effects, but they get the benefits of the medicines, and
Or,
then
you know,
use the psychological services as much
yeah,
as possible.